Morning, Trudy.
Good morning.
Thanks for joining.
Of course, you look a little bit lonely.
Just a little bit. Always welcome to join if you're in the Salem area.
Well, if I was in the Salem area, I would be in there.
Nice. Wonderful. Hey,
Good morning, Jamal. It's Lisa. I have to always change it from Brittany to Lisa initially.
morning, Lisa. Welcome.
Thank you.
See folks are filtering in here. We're going to give it a couple more moments. We'll get started. Ryan's joined, Babesh, Phil, Matt. Good morning to you all. Good morning, Angie.
Good morning. Morning, sir.
Good morning.
Hey, morning. Linda Manning's here with Capital Dental. Good morning, Linda.
Morning.
Zyra's joined. Good morning, Zyra. Gonna give it another couple moments here before we get started. Good morning, everyone. Thanks for your patience. We'll get started in just a moment. We're waiting on folks to join, and I think our co-chair will be with us in just a moment.
Oh, I'm here, Jamal.
Bruce is here. Hey, Bruce. Good morning.
Good morning. Hey, I just haven't said anything because I don't know why my screen is not loading well with the slides. So give me just one sec here.
Yeah, no worries. Take your time. All right, I see Hannah and Sarah and Tricia have joined. Good morning to you all. And Caroline. Got a good group. And while Bruce is his screen is loading up there, I put a event in the chat that we're planning, which is the result of some of the work of our childhood healthcare access work group around sort of like a webinar or community conversation around connections across perinatal care and support providers. Trying to create that more seamless experience of care for folks who are pregnant or postpartum. And so posting the
Maybe
first.
you could get me some AirPods for my birthday and then you won't have to listen to any meetings.
Hey, Caroline. There we go. Muted now. So that event is in the chat. That does not require any registration. So we hope to see all of you in attendance if you're able to. Okay, Bruce, are you ready?
Yeah, Jamal, why don't we go ahead and continue it? If there's any other member announcements, we'd like to hear if anybody's got anything else to say. Everybody's so quiet in the member announcements. Jamal, I think in the name of expedience though, today, we probably want to take attendance in the chat. Am I correct?
Yep, that works. If folks can place their name and organization in the chat, that would be helpful. Or if you're driving or on the phone, just chime in and state that you're present, and we'll document that.
This is Benu. I have an announcement that I'd like to share.
Please.
Yeah, go ahead.
Okay, great, perfect. So this has been about 4 to 4.5 years in the making, and required my participation on High Talk, and as well as co-chair of the HIE committee with the state. And I'm really happy to share that Capital and the General Dental offices, in affiliation with Reliance HIE, we've now built a custom design system between our non-certified EHR to be fully integrated with Reliance's health information exchange system. So by November 1, all of our care delivery systems, whether it's our co-locations or brick and mortar offices, by our, I mean the affiliated practices of the general dental offices, or the mobile dental vans, have access to near real-time physical health information of the patients when they present, and also the ability to write into Reliance's health information exchange for exchange of information with for electronic exchange of information with our PCCs. I'm really hopeful that within a year's time, after we've kind of straightened out all the kinks, then we could share this type of technology with Capital's other providers, to demonstrate that you can actually start building the infrastructure of medical dental integration and reduce the barriers that exist. So really appreciate the HIT subcommittee with I think when Justin Keller came in as a consultant, a lot of the discussions that we had at that, even though I had personally served on the state's as co-chair of the HIE with Brian Wetter, I think a lot of those discussions that had happened helped with kind of convincing the risk management team or medical malpractice liability organizations of our parent organization to really say yes to this. And so, I think this is definitely a co-created moment over the last 4 years, and couldn't have done it without leaders such as Lavinia, as well as everyone here around the table that participated. But wanted to share that really great news that finally, not only are we kind of the first in the state to do this, but we're first in the country to take a non-certified EHR and fully integrate it with a health information exchange for care of, for dental care. Thank you.
Thank you, Manu. That's wonderful news. Do we have any other member announcements? Well, as a reminder, we'd like to welcome everybody. This is the October 22nd meeting for this CAP group. We do want to remind as well, we do have a brief period available here if we do have any public comments that wish to be made. All right. So Jamal, I think I'm going to hop right into the CAP shared savings initiatives that we've got presented before us today and kind of do a quick summary. Are you okay with that?
I think that sounds great.
Wonderful. So in this case, we are going to take them one at a time. Just a reminder, we did have the Capital Dental Care, Equitable Dental Care, and High Needs School Initiative. $60,000 was requested. It supports a full-time dental health coordinator to ensure children with urgent dental needs receive timely access to care. Care coordination provided for both insured and uninsured within and outside the Capital Dental Care Network. The key participants were Capital Dental, Marion and Polk County School Districts, and local dental offices. And Capital Dental will conduct school-wide dental screenings in high-needs schools in Marion and Polk counties. So a reminder, we did do an online cap vote. I want to thank everybody once again. These votes that we've been doing online have been overwhelmingly efficient and timely. In this case, we had 20 total responses, and of which we had 20 members approved, 0 members disapproved, and 0 declined. So at this point, the only thing we need to do to officially pass it is we do need a motion to approve, as well as I believe we just need a second, don't we, Jamal? Because we've already voted to approve it, correct?
I think we'll go through the full motion, but Bruce, before we do, I think it's important for folks to declare any conflicts. So, you know, I know that Dr. Chaudhry, as a member of CAP, this being a Capital Dental initiative, want us to, you know, declare any conflicts to ensure that we're sort of operating in concert with our conflict of interest policy.
So obviously,
Oh.
sorry, sorry, Jody, go ahead. You first, please.
Oh, sorry. I was just saying I might have a conflict of interest for the fact that I am one of the Marion Polk schools that partner with Capital Dental. So I just wanted to say that.
Thank you, Jody.
And I also have a conflict of interest, just, sorry, capital spelled with an O, it's CAPITOL. It's okay within the body, but anyhow, yes, I also have a conflict of interest as I serve as president of Capital Dental Care. Thank you.
Thanks, Dr. Chaudhry.
Okay, so now we have established the conflict of interest, which will obviously not be voting then. For all those voting members, we do want a motion to approve, and after which we will do one more final approval.
And this is Matt Hatler. I'll motion to move forward with the Capital Dental shared savings request.
I second and vote to approve.
I want to ask if Bruce, we'll ask if folks are all in favor and just take a verbal vote.
Okay, and then all those who vote to approve indicate so, please.
Aye.
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 And do we have any members who disapprove? All right, I think the ayes have it,
And Bruce,
Jamal.
we can also,
The abstentions just for those conflicts, I think.
yeah, if there's any abstentions.
Yeah, so Manu and then Jody, I don't know if you officially abstained, but we want to make sure that's noted.
Yes, I officially abstain. Thank you.
All right, it looks like we're ready to move on to the next initiative. And the next initiative was the Compass Perinatal Support Family and Community Support Group.
And Chris,
Just
a second. So, just wanted to note that it sounded like the motion officially carried. So just wanted to note that for our minutes.
Yes, it sounds like we are officially approved. Motion
Awesome.
carried.
Okay.
Okay, where were we? The Compass Perinatal Support, Perinatal Family and Community Support Initiative. $120,000 was requested. A reminder, it was for a local nonprofit serving pregnant and postpartum families in the region, empower individuals with knowledge and skills to have healthier pregnancies, safer childbirth experiences, and better overall postpartum health. Funding will support community childbirth education, inclusive and in-person child birth classes offered at no cost to Marion Polk region, doula training and or doula training and mentorship, local training and mentorship to include the number of doulas in our area, and a perinatal peer support groups for parents navigating the perinatal period. Our results from our preliminary online CAP vote, we had 20 total responses, 18 members approved, 1 member disapproved, and 1 declined to answer. So we do want to put it as a formal motion to go ahead and approve. If we have somebody.
Hey, Bruce, it looks like before we do, Dr. Carroll has her hand raised. Dr. Carroll, did you have a question or comment on this initiative?
Yeah, just a quick question about process. I think I'm a little confused about the preliminary votes online versus then the formal votes in the meeting and why we're doing both.
Yeah, Bruce, I'm happy to describe the process there. So the shared savings work group established a process in, I think, June of this year to really vet these initiatives. And in the interest of transparency, so the initiatives come into the work group to be vetted to ensure that they meet CCO medical loss ratio requirements, that they favorably impact the CCO's medical loss ratio, and constitute what's described as a quality improvement activity within the federal regs. And so through that process, initiatives that the work group deems have adequate MLR favorability, good return on investment for our community, they're impactful, they have a good equitable impact for our community. Those initiatives are advanced forward to the CAP through the online vote. So sort of that preliminary vote that's being described here. The point of that is to really give CAP members an opportunity to read the details of each of these initiatives on your own time and indicate whether there is initial support or if there are concerns or comments that we can sort of take back to the work group and flesh out to better determine if we need to modify anything or request modifications to initiatives, or determine if it's something that should actually advance forward. From there, the process is any initiative that garners at least a 50% favorable approval during that preliminary vote is brought forward to CAP for formal approval through our formal Roberts rules in the meeting. So that just helps to sort of create that transparency and an opportunity amongst CAP members to review each initiative, as our agendas during this meeting are pretty jam-packed and we don't always have time to dig into each initiative at length. And so it helps us to sort of streamline which initiatives to bring forward to CAP for formal approval, if that helps, Dr. Carroll.
Yeah, okay, thank you.
And it's something that we can consider as well if we want to look at, in the interest of expediency and efficiency, finalizing and confirming the online vote as the formal vote. That's something that we can also look into if folks have interest in that. Okay, I'll turn it back to you, Bruce.
Yeah, I think I'm allowed. I'd like to go ahead and motion to approve.
Okay, we'll ask if there's a second.
I second.
All right, so we have a motion, we have a second. Can we go ahead then and for all those who would vote to approve, please indicate so.
Aye.
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 All right, and are there any members that disapprove? Are there any of those that decline to answer or abstain? All right, Jamal, I believe we have all of our indications and an overwhelming approval at this time.
Wonderful. So,
okay, if we have that documented, the only thing I do want to remind before I let Jamal take over and introduce our next speakers is that if you have not done so already, please do indicate in the chat your name as well as the organization you do represent. I want to thank everybody for helping to approve these shared savings initiatives, and we are excited to see their effect in our community. So thank you. Jamal, if you want to go ahead and introduce.
Absolutely. Thank you all. That's exciting news. And we'll be sure to keep folks posted as those initiatives roll out. So with that, I'll go ahead and turn it over to Hannah Tacky and Trudy Townsend with Pacific Source to discuss the health equity measure related to meaningful language access. Hannah and Trudy.
Hey, good morning, everyone. Hannah Tacky. I'm the Quality Incentive Measure Program Manager for Pacific Source across all of our regions and the Legacy Pacific Source IDS. I'll send it over to Trudy for a quick introduction before we kick off.
Good morning, everyone. My name is Trudy Townsend, and I am the Training Facilitation Manager at Pacific Source. I run our provider training program and also our healthcare interpreter training and support program.
Thanks, Trudy. So we're here to talk a little bit about the health equity measure. So that's our meaningful language access measure, as well as the healthcare interpreter program. So Trudy will take bits about the program and I'll talk about the quality incentive measure. So as you can see here, we met the measure as the Marion Polk CCO last year in 2023, which is a really big thing to celebrate. There were only 4 CCOs who met this measure out of the 16 across the state. And Pacific Source was 3 out of 4, and Marion Polk was one of those. So very exciting. Take a moment. I know 2023 probably feels like years and years ago, but just wanted to take a moment to celebrate that with everyone here. Next slide, please. So for 2024, there's been some adjustments to the measure, particularly for component 2, which is about how we report this data to the state. So in the past, there has been a sample that some of you on this call, your organizations might have received a request for you to complete a spreadsheet from us. So the way that Pacific Source did it in the past was get our sample, identify which members were seen by specific providers and ask those providers to report. Now the measure is full population, so it's not based on a sample of members. And these members are reported on in our quarterly language access reports. So essentially taking a report that was in existence and kind of combining the ask so that we ultimately end up with our performance at the end of the year with our final report in April. So those are submitted to the OHA, as well as component 1 still remains. We have a self-assessment where we need to be progressively building a higher quality and more robust infrastructure to serve our members who have language service needs. So we, as the CCO, respond to that component. We do hope to have some time for questions, but if anybody has any questions, this is a brief summary of the measure. So if you have any questions, please feel free to let me know. Otherwise, we can move on to the next slide. Yeah, thank you. So this is just, and I believe these slides will go out, so you all will have time to look at it. We wanted to really get to discussion today. So we have many different departments. As you can see, we have 6 listed here that work on this measure or work related to language access. So I am part of the quality team. We do oversight and reporting. We also have a population health team that supports on workflows, and our analytics team has become really critical in this, even more so. They always are, but even more so because of that quarterly language access reporting. So we had to work over the course of the last 9 months or so to identify how we were going to essentially combine these 2 methodologies to be able to report to the state on this. Next, please. Let's see here. Okay, so this is Trudy. I'm going to send it on over to you.
Thanks, Hannah. As you can see from the last slide, Pacific Source does a ton of work to try and get us, all of our CCOs to pass this measure. The work that we do in the Healthcare Interpreter Training and Support Program is part of the really proactive work that we're doing to try and build the workforce for qualified and certified healthcare interpreters across all of our regions. I'm so excited about the way that Marion and Polk has really made use of this program. You can see that we have helped 44 interpreters from the Marion and Polk CCO go through our entire program and successfully get listed as a qualified healthcare interpreter on the OHA registry. We have I think a 99% success rate in our program, and success is measured by interpreters making it through our program and getting listed on the OHA registry. We're really excited about that. It's a higher success rate than any other training program across the state. So pretty excited to have that. The program's working well. We're kicking off our last cohort of the year next Monday. And that cohort is full. So we're thrilled about that. I also want to note that we started offering free language proficiency testing for bilingual providers. So we're doing that as a proactive way of trying to also meet this measure. If a provider is bilingual and they are offering services in a language other than English, so another language, if they have passed language proficiency, then they can see our members without an interpreter. The members who have a flag for needing an interpreter, they can see our members without an interpreter, and that visit does not count against us in the measure. So the way we measure this is, did the person need an interpreter, and did they get one, right? So if that would come up as a flag that says, no, they did not get one, but then we could look and see, oh, they didn't get one because they're being served by a bilingual provider. So we started offering proficiency testing for bilingual providers. It's a pretty simple, easy process. You just fill out a short application at this link, and then we have a coordinator who will help you get your test scheduled with an OHA approved testing vendor. So those are the things that we're doing in this program to really try and be proactive, build the workforce, and be able to have language services available for our members. You can go to the next slide. Thank you. So I'm going to toss it back over to you to talk about documentation and all the things that we need, Hannah.
Yes. Yeah. Thank you, Trudy. Trudy's team does amazing work, and having an in-house program is really such an asset. And we hope to engage more folks. So please ask us any questions or get connected with us so that we can help get any of your staff through that program. So this is then kind of the call to action to ask for all of you. The number of times we say document on this slide, I think, is really indicative of what we need, right? So we need this to be documented, any services provided, as well as billing the appropriate code, the T1013 code, so that we can pull that information into that reporting. Since it has changed, it's all based on claims and then vendors who provide these services to our members, and we receive invoices. So thinking about our data sources can be really helpful in tracing back what we need from you all as providers and those serving our members. So documentation, documenting everything is really critical. And then we also have workflow work. So implementing workflows to schedule interpreters, that's something that our population health team can help with, right? If there's workflow needs or questions. And then, accessing training resources for staff and interpreters. We have a lot of resources. Trudy's team is full of great resources and aware of other supports that we can help provide. And then making sure that you communicate any needs for interpreters and referrals. So when you send a member on to a specialist or something of that nature, and they have an identified language service need, then to please make sure that you communicate that so that they receive the care they need. Next slide. So this is our discussion, and we could stop sharing if that works, and that way we can, maybe see each other or talk. And just wanting to ask the group what your experience is. Are you having are you having any difficulties? What are some of the ways in which you think we could better serve our members? What are some of the barriers that you're seeing to not getting or to getting members language services? Anything that y'all are willing to share. I think we have about 5 minutes, Jamal, if I'm correct.
That's right. I see that Dr. Caroline, Caroline, you've got your hand up. You gonna go ahead?
Hi there, this is Caroline King. I represent Kaiser Permanente. So I have a few questions specific to my organization. So one is we do use a vendor for interpreters pretty robustly, and I just want to make sure that that is that data is flowing, and I assume it is because we do have a way of documenting, but please connect with me if it seems to be any gaps there. The use of that code, I've never used that code before when I've used an interpreter, so that's news to me, and I wondered if you could put the code in the chat because I haven't used that. And the third thing was at Kaiser Permanente, especially at one of our buildings, we have a whole module where many of the providers and the staff are all bilingual. And so your comment around those that are bilingual, we want to make sure that they're registered as such. Again, maybe we can connect offline, but I want to make sure that our providers that are bilingual are registered as such with you guys so that that data is showing in the quality data.
Caroline, both of those things are going to be so helpful, helping us to know which of your providers are bilingual, and having documentation of their language proficiency will help immensely. So that's great. I want to be clear about the code. If you're using one of our vendors, we are likely getting that data through our vendor, and we match our vendor data with our claims data to help with this measure. The code is for providers who have interpreters on staff, people who are offering interpreter services on staff. Those providers can bill for that service using that code. And I think that Hannah's going to put an FAQ in the chat so that we're really clear about when to use the code and when not to. But if you're using a vendor, you don't have to use that code. We're getting billed directly from the vendor.
Thanks for that clarification, Trudy.
Are there other questions or thoughts from our CAT members or others?
This is Ira, and Caroline, I'll connect you with Hannah and Trudy. I have your contact information, so happy to make that connection.
Okay. Well, thank you, Hannah and Trudy. That's very important. We want to make sure that folks are, especially where there is bilingual proficiency, that folks are registered. I understand that's a no-cost assessment that Pacific Source offers for providers as well. Is that right?
Yes.
Okay. So that's a great resource to make sure that your practices are getting credit for proficient language access services. So thank you both. We'll be sure to provide this information out to our members.
Thank you, Jamal. I will note that it doesn't look like I'm able to share any documents in the chat, so I will follow up with you and provide that FAQ as well as some additional information from the state.
Perfect, thank you. Okay, with that, so I'll turn it over to our guests from house call providers that we have on the line today. There's a new resource that Pacific Source has brought into the community through house call providers for in-home primary care services for DSNP members. So let me go ahead and turn it over to Paige and Rita from house call providers.
Good morning.
Good morning.
My name is Rita Isaac. I work with house call providers. I have a presentation that I was going to share. Am I able to share my screen?
Yep, feel free.
Neat. All right. Are you guys able to see this?
Yep.
Fantastic. My name is Rita Isaac. I'm the program manager for house call providers, and I'm here with Dr. Paige Josie, and I'll give it over to her to introduce herself as well.
Hello, I'm Paige Griffin Josie. I used to work at Salud Medical Center for about 20 years, and I was Dr. Griffin then, so some people may know me by that name. So I'm a family practice doctor. I do geriatrics primarily now. I worked at Salud for 20 years. Then I worked for Kaiser for a couple of years. When I was working at Salud, I stopped delivering babies and started doing more older adult care and realized there were quite a few patients that weren't able to make it into the clinic, or it was harder for them to come see me. And so then I started seeing patients in their home and then really fell in love with doing home-based care. And so I left Salud and worked for Kaiser when they had a primary care at home program. And then when that closed, there was nobody else doing really team-based, home-based care in Marion County. And so I didn't want to do it on my own. So I ended up working for house call providers and have been commuting up to the Portland metro area for the last 3.5 years. And I am so done of driving through Wilsonville. So I finally convinced house call providers to expand into my home territory of Marion-Polk County. And so that is what we're in the process of doing now, is expanding house call providers down here so I can commute 5 or 15 minutes instead of what I was doing before. It's all about me. No, it's really about, providing the care that patients really need. And by the way, I do speak Spanish. So that's another little addition there. So.
Perfect. Thank you, Dr. Josie. All right. So today we're just going to go do an overview of house call providers, primary care, discuss our patient population and our referral process. House call providers, our mission, vision, and our values. Our mission is really just improving lives by bringing healthcare home. Our vision is to sustainably transform home-based medicine to all homebound adults and those living with serious illness to access care that it really improves their quality of life. Our values are authentic relationships, collaboration and teamwork, problem solving, and exceptional clinical outcomes, as well as social justice. We are going to be celebrating next year 30 years of providing primary care to the Portland Metro. So we're pretty excited about that as well. So we have 3 clinical programs serving patients across a variety of home settings. So we have our home-based primary care program. We have a home-based advanced illness program called ACE, as well as a home-based hospice program. For our expansion to Salem and Marion-Polk County, we are only bringing our primary care program. So we will be working with community partners for palliative care as well as hospice care. So our primary care program really provides home-based primary care through a palliative lens. We're currently serving around 1,700 patients in the Portland Metro and have just recently expanded to the Marion-Polk counties. We utilize a multidisciplinary care-based team, including providers, nurses, social workers, care coordinators, pharmacists, chaplains, and we have a robust back office staff. As experts in geriatric care and the oldest and largest in-home primary care provider in Portland, we really strive to provide the patient-centered care for our patients and their loved ones. Dr. Josie, do you want to talk about our patient population?
Sure. So we primarily serve four high-risk groups of people, the homebound elderly, and that's really the majority of my patient population at the moment. Then there's people with physical and developmental disabilities, people with complex medical, behavioral health and social determinant challenges, and then people at the end of life. So I tend to bridge patients from like a normal primary care kind of medical issues all the way through to hospice care. I usually do a lot of palliative care because that just ends up being what I do. I think the next slide shows them like our different, yeah. So I'd say the majority of our patients are older than 80. Then we do have younger patients. I've had quite a few that have like cerebral palsy and are in group homes or that kind of thing. And then, the oldest patient's 107. I just admitted a patient who was 100 years old, and he was quite a hoot. So our mortality rate is pretty high because we are taking care of patients at the end of their life. So it could be 20 to 25% annually. I think I lose about 3 to 4 patients a month typically. Most of our patients have 4 or more chronic conditions. I mean, the reason that these older adults or patients are homebound is because they have so many complicated medical issues. Most of our referrals come from adult care homes, assisted living communities, health plan staff. From state caseworkers, home health, hospice. We get referrals from family and community providers as well. So they really come from all over. So these are our primary diagnoses. 41% is dementia. I think that is low because I always say like half my patients in assisted living really have some kind of cognitive impairment that hasn't been diagnosed. So, but a high number of patients with dementia and just the usual chronic morbidities of hypertension, diabetes, kidney disease, constipation, and then significant number with, chronic mental illness, whether it's, depression, anxiety, or other chronic mental illnesses. A portion of them, yes, are homebound and bedbound, making them homebound. So the primary team involves the primary care provider, which could be a doctor, nurse practitioner, physician assistant. Then we have a social worker, a registered nurse, and those are also able to make home visits and see the patient where they live and care for them there or do phone visits. And then the back office staff include a scheduler, a care coordinator, intake specialist. We have a DME coordinator who is just a queen about getting things that we need, and then a clinical pharmacist as well, which helps navigate all of those things. And then we use services that provide radiology and lab for those kind of services that can come into the home and do those, and then also use home health and hospice in the community. This slide always confuses me because I don't know where I'm supposed to start. So this is sort of our care model. So it starts with the chronic condition management, which is basic, primary care. We also are able to do acute illness treatment, which is just kind of urgent care things. A lot of that is coordinated virtually, depending on where I happen to be that day. We have preventive care, which can be flu vaccines, doing fall and other high-risk assessments, cancer screenings along that line. And then a lot of advanced care planning because our patients are usually transitioning from one level of care to another or one level of function to another. So, discussing goals of care, having a accurate pulse, being sure advanced directives are in place, and then referral to hospice when the time comes.
Thank you, Dr. Josie. I'm going to talk a little bit about how to enroll in our primary care program. So we are currently looking for providers in the area. So we are going to be expanding the zip codes that we're able to serve. But right now, our zip code service is 97301, 97302, 03, 06, 97310, and 97317. So I'm hoping and then the next month or so, we're able to expand these zip codes. We do have a provider that we have that might be taking this role. So we're very excited about that. Our insurances that we're currently supporting our Regents, United Healthcare, Providence, and of course the Pacific Source, decent population. Really the process to come on service is making sure that folks are appropriate for our service. So really those are folks who are having challenges getting to a traditional brick and mortar clinic, right? So they don't have to be bed bound, but they do have to have some kind of difficulty getting to traditional, traditional clinic. You can submit an application to our intake department via email, fax. We currently just put our application on our website as well, which is probably the fastest way to get it through and get it processed. And we also take applications by mail. And so if there's ever anybody who doesn't maybe have access to some technology, we're happy to mail out the application with a self-addressed envelope to help kind of support getting them what they need to come onto service. I think a big piece is just making sure consents are signed by the patient or the power of attorney. And then scheduling of the first visit really just depends on how many applications we have and kind of where the wait list is. It could take anywhere from 8 weeks to 10 weeks, or some months it can take 3 weeks or 2 weeks. So it just all varies. And thank you. I wanted to open it up for questions.
Lisa, I see you've got your hand raised. Do you want to come off mute?
Yeah. Hi, this is Lisa Ladd from WVP, and I just want to say that we're really excited about this program. Bhavesh shared information with us last week, and we did an internal assessment of potential members that meet the criteria or the diagnoses that you are treating. So our next step will be to schedule a meeting and talk about that and see how we can help partner with you to deliver these services. So we're very excited.
Oh, thank you so much. We are so excited to be in the area. And I'm originally, I live in the Portland Metro, so I'm new to Salem. So I've been kind of cold calling and knocking on doors and talking to providers. And so we appreciate any support.
Great.
Thanks. Other questions for Rita and Paige? And yes, to Lisa's point, thank you to Therese and Bhavesh at Pacific Source for bringing this forward and ensuring that our CAP is informed of this resource.
Hey, Jamal, I just wanted to say that it's critically important that this gets shared with other providers out at the clinics. And so, we're taking this on a little bit of a roadshow around to make sure that we connect with people on the ground and ensure that they have the opportunity to ask questions. It does mean that, for some physicians, they may feel positive about those members that aren't making it to see them, to ensure that there's someone out in the community that can help that member. And so we don't leave people unable to seek care. And so I think those are the critical elements, is to think about members in your panel who are not able to get in and who need support for their chronic conditions. Thanks.
Thanks, Bhavesh. Caroline, I see you've got a question in the chat. Did you want to come off mute and ask that to the group? Or?
Yeah, sorry, I was working with my student here, and so I didn't hear all of the information, and I just wondered specifically for how if we identify an appropriate patient, how do we refer to house call providers? As a primary care physician, how do we transfer?
Yeah, I can share our application with the team and the list of insurances that we take currently. We don't charge any additional fees for our services, but we do have to be contracted with the insurance piece. And really, if you think about folks that you're concerned about that are not making it into clinics, that are having difficulty getting into the clinic, that just don't want to leave their home. We have some patients with agoraphobia that, could get in their car and drive to a clinic. So really those folks that are just having difficulty getting to a traditional brick and mortar clinic, multiple chronic conditions, they could have Alzheimer's, dementia, cognitive issues. We're not as strict as like home health would be criteria. We just want to make sure that we're saving our panel spots for folks who really cannot get out and access traditional healthcare. Dr. Josie, is there anything you want to add on appropriateness or like
I
the
think
right criteria?
It's really I'm sticking our website and our phone number in the chat, so if people want to look for the application. But it's really what my criteria is pretty low. If it's, the patient has a harder time getting into the clinic than it takes for me to get to them. But the other piece of that is they really need to be homebound in the sense that they aren't driving. They could still be going to specialist appointments, just not like if not driving themselves. And I think that's part of the the technical CMS homebound criteria. The other piece is a lot of times when the patients are in an assisted living or a memory care or something like that, it's so much easier for a provider to be in that facility to see really how the patient is doing there and who's actually who the players are and that kind of thing. So I think, any patient in an assisted living, memory care, adult care home, they all qualify because they've got assistants in their ADLs or IADLs. But they also, I think it also is a great spot because I actually get to know the caregivers and the providers in the facility themselves, and it just makes managing their care so much simpler. So.
Yeah, thanks for that. I guess really my question was more just what you answered in the chat. How do we actually, if I'm a primary care physician at Kaiser Permanente seeing a Medicaid patient in this case, so that would be the only insurance we're talking about here, how do I get that transferred, and want to be concrete with our staff and things. So we go to this website, is that right?
Yep.
Okay.
And then if there's any questions, you can call the office and they'll take
Okay.
you to the intake person.
Or the patients, because we have agreement with Pacific Source, and so they've assigned them to KP. But if the patient calls Pacific Source and says, I'm homebound, et cetera, are they going to be able to say, we have a different PCP for you that can see you at home? Or is this going to be needing to be rerouted from the clinic?
Yeah, I think I can chime in there. So my name's Teresa McIntyre from Pacific Source. I'm the lead on the Pacific Source end. So we would let them know that we do have a program. All of our customer service have been educated on the program, the area that we serve, and the population that we serve. And just to reiterate, this is our DSNP population. So they have Medicare and Medicaid coverage and are enrolled in our DSNP program, which is dual special needs. So they really are, we chose that population to start because they really are the most vulnerable in the community. And then what we did on our end, just to kind of get started, is I pulled a list of members that met the criteria in terms of the medical conditions and did not have a PCP assigned in our system. So that does happen occasionally, even though all Medicaid members have an assigned PCP. Sometimes when providers leave or other circumstances, they may not have one listed in the system. So that's where we started, and now Bhavesh is really helping us to get the word out to primary care providers that they can direct refer. So you can also reach out to me and directly. That works too.
Teresa, I did have a question about management of members from the perspective that, just to kind of call out that kind of the PCP who's looking after the member changes over, right, to one of the house call providers. And so they then also take on all the metrics and measurement for our quality metrics. Presumably with the work being done with other CCOs, house call providers is very, very well set to know all our CCO metrics and all the things that we need to kind of focus on to make sure that we're hitting any of those things.
Yes, we worked with them just around what those metrics are, so I think that they're well versed in terms of that.
There are plenty of people chasing me down to be sure I'm doing the right thing and documenting the right thing and whatever. So somebody's doing it, being sure they're keeping me on track.
That's great. Thank you so much.
I just wanted to say that this has been a much needed service. So thank you for, pursuing coming to Marion Polk. And I will be reaching out to you for sure.
My pleasure.
Thank you.
I work with Northwest Senior and Disability Services. So older adults and people with disabilities are the folks we work with. So I'm looking forward to working with you.
Great.
Thank you.
Paige, did you say how many patients you're trying to collect as a panel? Like, what would be the goal?
Like
to have a Marion Polk?
150, 160 per provider.
Okay.
And the more patients I see down here, I can hand off more in the north. So I'm like all about gathering as many as I can.
Got it. I'm sure there are plenty.
All right. Well, thanks so much, Paige and Rita. It's such a wonderful resource to bring to the community. Folks, their contact information is listed in the chat. We'll also be sure to send out their information in a follow-up email. But thank you for joining us, and we're excited to see this service in the community.
Thank you.
Yeah.
All right. So folks, we've got about 5 minutes left. I'll provide just a few general updates on some activities happening around the clinical advisory panel, as well as some of the items that we're needing to plan as a panel for 2025. So if I can move the slides forward here. Okay. So one of the things I wanted to start off with is just a really heartfelt thanks to many of our CAP members for considering participation in OHSU's Autism Assessment Capacity Project, which is really designed to build that local screening and diagnosis capacity for evaluating autism and diagnosing locally here in the community. Many of you will recall we've, as part of Dr. Bruce's co-chair initiative, we really sought out early in this year and late last year to determine how we can increase screening and diagnosis capacity here in the Marion Polk region. As we know, kiddos and families where there's suspected autism, when there's a need to refer up to Portland for formal evaluation, that's sometimes taken families as long as 2 years or more to get into services. And so we've been engaging through the funding that's been provided by CAP through our shared savings fund and Dr. Bruce's leadership in bringing this forward. We've been able to identify a program that looks promising to create that local capacity and train PCPs in our area to be able to diagnose confidently and be supported through ongoing ECHO services with OHSU. So we've been working with Dr. King at Kaiser Permanente, WFMC, Yakima Valley Farm Workers Clinic, Salem Health, Santiam, Woodburn Peds. All of your organizations have been so eager to assist in piecing in this gap in our community and showing that this can be a very action-oriented body to meet our community's needs. And so appreciate you all considering that and considering and bringing that forward to your organization's leadership. So we'll certainly keep the CAP posted as we look to hopefully kick off a cohort with OHSU, a cohort of PCPs in the Q1 time period of 2025. On that note, so that originating as a co-chair initiative, I did want to remind folks that we are currently accepting nominations for our new set of co-chairs, which we're hoping to get started in 2025. This is a really cool position. So as that last initiative from Dr. Bruce shows, this is a position where folks who are voting members of the CAP can really lead in our community and help to drive the strategic vision for improving healthcare throughout the Marion-Polk region. The time commitment can be relatively low, as low as 30 to 60 minutes per month, working with myself to ensure that we are structuring an agenda and the strategic plans for our CAP moving forward through generally a 30 to 60 minute meeting per month. So please, if you're interested in being a co-chair or you feel like one of your colleagues would be very strong, send me an email, let me know, and we'll consider seating you as a co-chair. Another big announcement is the board of the Health Council has recently approved some additional funding for our shared savings work group. This is funding that is actually not exactly shared savings, so it sort of changes the scope of our work group a little bit, where we do anticipate that some of the QIM dollars that are associated with the social determinants of health referral and screening metric, as well as the social emotional health aspects of kindergarten readiness metric, will come to our what's currently called our shared savings work group to determine how best we invest those dollars in quality improvement and infrastructure and activities that that improve our ability to improve social emotional health, as well as social determinants of health screening and referrals throughout the community. So that's really a testament to the process that the CAP has established to drive investments out into the community in a way that is transparent and vetted and open to the wide perspective of clinicians and practices and community organizations throughout our region. So more to come on sort of the shifting scope of the work group, as well as the dollar amount that the new amount of funding that is available to our work group. And certainly reach out if you have ideas for a new name for the work group, right? Because we are no longer just the shared savings work group. Lastly, we do have, I posted something in the chat around our perinatal event coming up, which is the result of some of the efforts through the Childhood Healthcare Access Work Group. But I did just want to touch on the Marion-Polk Access to Care report that our consulting group, Creech Consulting, is working on. So they are currently synthesizing all of the input that's been provided by you all as the CAP through not just the September SWOT analysis that we did last month, but also the August Forces of Change discussion that we had with Justin Hopkins as part of the community health assessment, and many other inputs. So many of you were interviewed individually by Creech Consulting Group. They've also been pouring through other reports and data sets that indicate different access indicators for our region. So all of that information is being collated and synthesized to produce those action-oriented recommendations that we can take forward to invest in improving access throughout the 2025 calendar year. So we are expecting that those recommendations will be finalized and ready for our review December 4th. So more to come on that. I know we are over time, so appreciate folks hanging on for an additional 2 minutes. Thank you all for your time, as always. This is an exciting time to be a CAP member. We are moving quickly to drive community health improvements and clinical interventions. So thank you all once again, and I look forward to seeing you soon. Take care.
Thanks, Jamal.
Thank you.